Greetings to all. Welcome to OrthoTV. Today we have with us Dr. Aditi Padki. Dr. Aditi Padki is currently working as a consultant physiotherapist at Tulip Healthcare. She has completed her bachelor's from Nair College, Mumbai College of Physiotherapy. So we are more than happy to have you, ma'am. Requesting you to kindly start with your session.
Okay, thank you for the brief introduction, Dr. Shivani. And I will surely start on today's topic. I just share my presentation. So let's start with today's topic. So today we are going to discuss about pleural effusion. So you may have seen cases of pleural effusion in hospitals, let it be ICU or it can be wards also. So pleural effusion comes as a secondary condition to a primary condition involving mainly heart or lungs. So it can be any respiratory condition of lung or a congestive heart failure, following which you can see patients with pleural effusion. So to start with, we will revise the basics of pleura and the pleural cavity. So next slide. Uh, so can we have the next slide? Yes. So starting with the basics, now you know that the lung has pleurae. So there are two types of pleura. There's parietal pleura, which follows the walls of the thoracic cavity with cervical, costal, diaphragmatic, and the mediastinal parts. And there's visceral pleura, which is also known as the pulmonary pleura, which is attached throughout the lung, which is inseparable from the lung. So there is a pleural cavity, also known as pleural space, which lies between both the pleuras. So the two layers are continuous with each other around the hilum of the lung and enclose a potential space known as pleural cavity. So usually the pleural cavity or pleural space contains 10 to 25 ml of a serous fluid which is there for the movements of the thoracic cage to help in lubrication. So when this 10 to 25 ml of pleural fluid rises up to 3 liters or more, it is known as pleural effusion. That is abnormal amount of rise in the pleural fluid is pleural effusion. So with the next slide. So in the next slide, as you can see, there is heart, there is lungs, and there are visceral pleura, parietal pleura. In the red, you can see the parietal pleura, and in the blue, you can see the visceral pleura, which lines the lungs. So between parietal and visceral pleura, there is pleural space. So can we have the next slide? So there are two types of pleural effusion. There is transudate type of pleural effusion. The trans means that you move across. So the pleural effusion of transudative type, it accumulates due to changes in the hydrostatic pressure within the pleural capillaries. The protein content in this type is very low. So elevation in hydrostatic pressure is commonly due to left or right heart failure. Congestive heart failure is the single most common cause of transudative type of pleural effusion. So due to increased pressure, more fluid moves out of the pleural capillaries and less is reabsorbed. The next type is exudative type of pleural effusion, which accumulates due to changes in the permeability of pleural spaces or surfaces. So there is a high protein content. So usually there is an inflammation secondary to tuberculosis or secondary to any other malignant condition. There are inflammatory processes going on inside the lung, so due to which there is a permeability of the pleural space is increased, there is leakage of the protein content and excess fluid which is developed, from the lung into the pleural space. So the protein content of this type of pleural effusion is quite high as compared to transudative. So these are the main two types of pleural effusion, which are the transudate and exudate. So in the next slide, we'll see the pathophysiology. So capillaries in the parietal pleura, they receive blood via a high pressure systemic arterial circulation, and capillaries in the visceral pleura receive via low pressure pulmonary circulation. So there is a gradient between both of them, wherein the fluid is constantly moving from parietal to the pleural space enclosed between them and to the visceral pleural capillaries. So the pleural fluid formation and pleural fluid resorption is balanced in this way so that the fluid does not accumulate beyond 25 ml. So when this balance is disrupted either due to congestive heart failure, that is causes of the heart, or due to respiratory causes which cause inflammation and exudation, there is accumulation of the fluid which ultimately limits the lung expansion, and it also causes a restrictive lung deformity. So in the next slide, we'll see more about it. So the clinical features, the presentation of patient which comes with pleural effusion. So the signs are, if you see the PFT, that is pulmonary function testing, there are decreased lung volumes. If we take an X-ray, the chest X-ray, you can see the blunting of costophrenic angle due to presence of fluid. In case of a massive effusion, the homogeneous opacity of fluid density is present and is seen on X-ray. You can also see the meniscus sign which is present in large effusions. ABG is usually normal. There are bronchial breath sounds which can be heard just above the effusion, and over effusion there will be a dullness and the sounds will be reduced. Pleural rub is present only in cases if the pleura is inflamed. So the symptoms. Patients will come with symptoms of dyspnea mainly in cases of massive effusions, and if inflammation is present, patient may also have a dry cough due to irritation or can have a pleuritic chest pain which will eventually wear off as the inflammation will heal. So in the next slide, we will see the X-ray presentations of pleural effusion. So on the right side, we have a massive pleural effusion. There is no meniscus sign. There is a mediastinal shift. The massive pleural effusion is exerting pressure on the mediastinum, leading to tracheal deviation, as you can see here. And on the left side, we can see a large pleural effusion, which is showing or displaying a meniscus sign. So you can see this meniscus sign, and there may not be a mediastinal shift as it is not a massive pleural effusion. So in the next slide, so the medical and surgical treatment of pleural effusion. So first we can look for thoracocentesis, which is involving a passage of needle in just superior to the rib, which can be performed with a single needle or a syringe. It helps in diagnostic sampling of the pleural fluid for cell count, culture, and protein measurements. It also helps to relieve some pressure of the patient regarding the heavy work of breathing. The pleural fluid drainage with lung re-expansion involves placing a catheter in the pleural space. So in the next slide, we will see more about catheters. So there are chest tubes. Catheters from the size 7F to 14F are used. So inserting a pigtail or an ICD, that is intercostal chest drain, depends on the physician's choice. Larger tubes like chest drain are less likely to get obstructed and are capable of high airflow rates, whereas smaller tubes are easier to place like pigtail and are usually less painful than the intercostal chest drains. The placement is often done in the sixth intercostal space, and the mouth of the drain is usually facing to basally and connected to a water sealed chamber for easy drainage of the pleural fluid. So the removal of fluid is done when the pleural fluid is less than 50 ml for around 24 hours. With regular monitoring of fluid is essential to ensure the timely removal of the drain or the pigtail. So next slide, we can see the X-ray picture of a pigtail insertion done in a patient with parapneumonic effusion. So next slide. So thoracoscopy. Now this procedure involves placing a thoracoscope through an intercostal incision to visualize the lung surfaces, drain the pleural fluid, and perform biopsy. So biopsy can be done of pleura of the lung and take pleural fluid sample, and we can also perform pleurodesis. So next slide we can see what pleurodesis is. It is a process of fusing the parietal and visceral pleura together in a fibrotic reaction that prevents uh, further pleural fluid formation, and it seals the pleural space. So there are various methods to perform the pleurodesis. There is surgical abrasion. Then there is application of chemicals like doxycycline, minocycline, and talc. So this procedure is usually not recommended for massive malignant effusions, but can be used for benign ones. So next slide. So the physiotherapy management. So what is your physiotherapy perspective? What is our role in pleural effusion? So we have an important role in controlling and stabilizing the breathing pattern and to aid in the chest fluid drainage and clearing the chest secretions. So first we need to educate the patient. The very first step in all our physiotherapy protocols is to educate the patient. So we need to explain the patient about the underlying condition and the importance of rehabilitation and breathing exercises. So if a pigtail or ICD is inserted, few precautions need to be taken. So the precautions are avoiding strenuous activities, avoiding deep inspiration, avoiding drain position to be kept higher while ambulation or while mobility. So it should always be lower. Excessive pain or kinking should be reported if present. And any things that can increase the intrathoracic pressure should be avoided. So in the next slide, we'll see the for future management to maintain or improve the bronchial hygiene. So if the patient has secretion, we can give them postural drainage in sitting or lying position or a modified postural drainage according to patient's comfort. We can teach the patients for splinted huffing or coughing to expectorate the secretions. So re-expansion of the lung is the most important part in pleural effusion. So we need to focus on breathing exercises and spirometry. So starting with pursed lip breathing, so it works to improve the expiration. It requires active and prolonged expiration, so which usually prevents the airway collapse. So there is more marked increase in the lung volume and a decrease in the breathing frequency if we teach patients for pursed lip breathing. Then there is active expiration, which lengthens the diaphragm and contributes to make it work to its optimal length. So active expiration, it increases the elastic recoil pressure of the diaphragm and the rib cage. Incentive spirometry can be used in lung re-expansion, and coach to spirometer is effective, which can be done like 10 to 15 times per day. It allows high volume of air into lungs and improves the oxygen intake and pulmonary capacity. So, for segmental expansion and diaphragmatic breathing exercises can also improve the underlying atelectasis and help in expansion of the lung. So, when you have a localized pleural effusion like mild pleural effusion, you can focus on segmental breathing exercises for the patient to improve the re-expansion of the lung. So, next slide. So to improve the mobility and aerobic capacity. So usually the pleural effusion patients are in hospital until the pleural fluid is drained, or sometimes they may also be discharged with mild fluid. So limb exercises in bed or bedside can be made to improve the joint range and the soft tissue length to prevent the deep vein thrombosis. So, simple endurance exercise training with appropriate modification like low level activity with gradual progression can be done. So, we can start the patient with sit to stand, we can start the patient with spot marching, like simple exercises which can improve the aerobic capacity. And walking with periodic rest will increase the exercise tolerance. So, intensity to be decided on the RPE, rate of perceived exertion, or an exercise test using the 6-minute walk test. So, you can ask the patient to walk for a certain distance, take rest, and then resume walking again. So, you will have to educate the patient regarding the handling of the catheter and the drainage bag. So, patient positioning, lying or tilting on the affected side. So, the side with pleural effusion, it will help in draining of fluid, and lying on the good side will make the patient comfortable and help in the pain free motion. It helps in increasing the ventilation perfusion ratio also. Next slide. So these are the references for pleural effusion. You can refer and read more about it. You can also read about empyema. Yeah. Thank you.
So thank you, Dr. Aditi, for such an amazing session. We had few queries actually. We had few doubts. So if you would like to answer them.
Sure.
So Dr. Aditi, can you just enlighten us on what challenges did you face while dealing with patients of pleural effusion, especially at an ICU setup?
So when you're dealing with patients at an ICU setup, so the patients in admitted in ICU for pleural effusions are mainly for massive pleural effusions, wherein the exercises you make them do won't be of much help. So first you need to start with some dyspnea relieving positions in case of massive pleural effusion. You can make the patient sit in their comfortable position and you can make them do per sleep breathing. As well as side by side you can monitor them for their vitals. You can also instruct them and the resident doctors for optimal positioning of patient for easy drainage of fluid. So that will help in the like some symptom relief of the patient. It won't relieve the symptoms completely, and you may not be able to start with endurance exercise or mobility exercise as of immediately because patient will be too breathless. So until the fluid drains a little bit and there's little relief of pressure on the lungs so that the work of breathing is mildly reduced, then you can start with other exercises. So the main challenge you can face is patients who are heavily breathless because of massive effusion, wherein you need to start with basic positioning and other dyspnea relieving position if the patient is comfortable. Okay, so I would like to thank you, Team Sancheti, for giving me this opportunity to present this topic on Physio TV. Thank you so much.
Thank you so much, Aditi. I would also like to thank Dr. Apurva Shimpi sir, our principal, Dr. Manisha Sangvi ma'am, our chairperson, and the technical team of Physiotherapy. Thank you.
Thank you.